So yes, I'm Dr Anand. I'm a GP in Hull with a special interest in lifestyle medicine, and I'm going to give you a short summary today on adult obesity and weight management. I also provide free training on physical activity for the management and prevention of long-term conditions, which can be delivered to GPs or primary care professionals. So declarations of interest, I can provide some different training topics, but I've had no funding from any pharmaceutical companies. I'm vegetarian, and just because I'm giving a talk on obesity doesn't mean I don't enjoy biscuit in my cup of tea. It is a common problem though, so if any of you are affected at any point, do feel free to take a break. So planning for the session, a little bit of background, a bit on diet and nutrition and ultra-processed foods, some of the benefits of weight loss, a bit around language and weight stigma, how to raise the issue in a minute, which is what all we've got sometimes, and then a summary of the services for weight management and type 2 diabetes nationally. So I'm not specifically going to cover the new anti-obesity medications, for example, but we can have a chat at the end if you're interested. So I'd like to start off with a poll. Hopefully you can put some answers in the chat. Which of the following is correct about obesity? There is more than one that is correct, but not all of them are. So can it be managed by eating less and moving more? Is it a chronic relapsing progressive disease? Is it caused by factors within an individual's control? Is it heritability between 40 and 70%? Most people not open to talk about it, and is willpower a problem for people living with obesity? So if you want to have a short think and then pop your...
Okay, so Julia has posted in the chat, she thinks that 1, 2, and 4 are true, but she's put 2 question marks, so she might not be sure. And
Yes,
Sally has posted, most are true except for 3.
Okay, perfect. Thank you very much for you guys for having a go at that. So I can confirm that actually only 2 and 4 are correct. So obesity it can't be managed simply by eating less and moving more. Okay, it's not as simple as that, unfortunately. And it is defined as by the World Obesity Federation as a chronic relapsing progressive disease now. It is a medical condition. It's not caused by factors solely within an individual's control. There's lots of other extrinsic factors at play. 4 is correct. So the heritability is estimated between 40 and 70%. It's a huge amount of genetic variation. Up to 1,000 genes are linked to obesity, according to Giles Yeo's Lancet article. And 5, most people actually are open to talking about their weight with professionals. According to a study in primary care in the UK, 80% were actually open to talking about it and find it appropriate. But willpower is not a problem for people with obesity. It's not as simple as willpower. It's much more beyond that. So some kind of myth busting to begin with, which hopefully will be helpful. So according to the World Health Organization, it's an abnormal or excess accumulation of body fat that may impair health, a complex multifactorial chronic disease, and NICE define it as an endocrine, nutritional, and metabolic condition. It comes under that heading by NICE. It's not only a condition, it's a global public health problem as well. And the rates in England are rising, both of overweight and obesity, including waist circumference in both men and women. You can see the figures on the screen there. And the huge cost to the NHS at the minute, £6.1 billion just to the NHS alone. In terms of BMI classification, that's still how we classify obesity. It's important to be aware of what the classifications are and that there's lower thresholds for patients from BAME backgrounds. So for white European patients, healthy weight is 18.5 to 25, overweight 25 to 30, and then class 1, 2, and 3. Class 1 over 30, class 2 over 35, and class 3 BMI over 40. The term morbid obesity is no longer used. It's just obesity class 3. And you can see the cutoffs are approximately 2 or 2.5 points lower on the BMI for patients from those different ethnic minority backgrounds, which is important because that means the cutoffs for referrals are also going to be lower. And the reason they're lower is because there's an increased risk of obesity-related complications at lower BMIs for those populations because of genes and predisposition. The problem with BMI is that it's a basic measure of height and weight. It doesn't take into account central adipose tissue, and it's therefore not accurate for identifying obesity-related complications. Okay, if you look at this real MRI scan on the right, there's 2 people with a similar age, gender, and BMI. But you might be able to appreciate the person on the left has got a lot more grey and fat. I'm not sure if you can see my mouse icon. You can, great. So there's a lot more fat, for example, and grey around the liver area, heart organs, even some of the joints, and that's going to be visceral fat there. Whereas the person on the left, a lot more crisp lines on the diaphragm and the liver, a lot more black going through, which is air. So despite the same BMI, huge differences in visceral fat, and it's visceral fat really, which is the definition of obesity and the problematic parts of it. So waist circumference is a proxy measure of visceral fat. It's still only a proxy measure, but it's better than BMI. And NICE want us to measure waist to height ratio, ideally, in patients with a BMI under 35. So waist to height ratio, WHR, simply waist divided by height in the same units. And if it's 0.5 or less, then it's a healthy weight to height ratio. It's increased if it's more than 0.5, meaning increased risk of complications. And it's particularly increased or very high risk of complications if it's more than 0.6 or 60%. If patients haven't got a tape measure, they can simply use a piece of string at home and measure their height with a piece of string, fold it in half, and see if the half fits around their waist. And the waist in this is not the waist where the belt buckle goes. It'll be halfway between the bottom of the ribs and the top of the hip joint. Approximately, that's where the waist circumference is measured, which is around the belly button area. In Tier 3 specialist weight management services, they go beyond simple measurements and they use the Edmonton Obesity Staging System, which is a more of a holistic measure of obesity, taking into account not only the measurements, but also functional limitation and psychology as well. So obesity is linked to lots of social and health inequalities, unfortunately. It's more likely to affect people from ethnic minority backgrounds and those in more deprived areas, with a gap widening. Hospital admissions with obesity are also higher in those deprived areas. And people living with obesity have got poorer job prospects, less likely to be employed, less productive at work because they're more sick days, and they earn 10% less as well. So really stark inequalities there and a bit of a vicious cycle. So why the determinants? I said it's not as simple as eating less and moving more. The government commissioned a foresight report in 2007 to the causes of obesity in this country. And there were over 100 causes. And they tried to put these into various themes. So this is one of the infographics from that report. There's lots of other themes that were there. So this is just showing some of the themes that were found as causes, not just food consumption, but production of food, society and cultural influences, psychology of the patient, biology, which we include genes and hormones, and then food environment, activity environment, etc. But you can see beyond that is multiple interconnecting lines showing the really complex nature of the problem. So this slide is from the World Health Organization showing the top 4 risk factors for death in the UK that are so-called modifiable. And smoking cigarettes is still the top, more than 70,000 deaths, but close behind is poor diet, contributing 60,000 deaths in the UK, which is a lot. And then you've got physical inactivity, which is slightly higher than harmful alcohol consumption. Now, it does say modifiable. We know that poor diet is not always modifiable for a lot of our patients if they're living in deprived areas, especially with the cost of living crisis. So it's important to bear that in mind. But I will now talk a little bit about diet. So this is the UK's Eatwell guide or Eatwell plate from, I think, 2016. It looks a bit retro because it is a bit retro. It's a bit old now. You can see there about a third fruit and veg, aim for 5 a day at least. That's been there for a while, that message. And then you've got a third, ideally whole grain carbohydrate foods. Then you've got a pink section for kind of protein foods, which include vegetarian sources of protein and fish and eggs, etc. And then you've got dairy and alternatives. Then you've got your junk food on the side of the plate, but still on the guide. You've got some traffic lights here at the top left, and then you've got water at the top. And we're limiting fruit juice and smoothies to a total of maximum 150 mils a day, which is probably a small glass of wine, which is not much for fruit juice and smoothies for 1 in 5 days. So that's the current UK Eatwell guide. And the problem is that when analysis has been done about whether this is affordable for the population, it's actually not affordable for a lot of the population. So that's termed so-called food insecurity. And so that's part of the problem with this. So this is Canada's food guide from 2019, a bit more recent and a bit more modern looking, and perhaps looking a bit more straightforward. It's got half the plate of fruit and veg, a quarter of protein foods, and a quarter whole grain foods with water on the side. So looks simpler, possibly easier to follow. It's also got no funding from any pharmaceutical or industry involvement. And it goes beyond just the what you eat to to other things as well. So it talks about a variety of foods, which is important for gut microbiome. It talks about eating habits, i.e. how you're eating, how slowly you're eating, etc. It talks about cooking more often and enjoyment of food. And it also talks about eating meals with other people. It's a social thing. Looking at food labels, limiting highly processed foods for the first time that's been put into the food guide, and being aware that marketing can influence food choices, which is again a closely linked to the processed food, which I'll come on to soon. But again, possibly not affordable for a lot of the population, unless perhaps they're getting support and guidance from a group or a charity in terms of where to get the things from and how to make it more affordable. So ultra-processed foods then, this is a NOVA classification, which is mainly for research purposes, and it's still a work in progress, but it's good to be aware of where the classification kind of comes from and what the thinking is at the moment. It's an ongoing process, so it may have changed or may change soon. But there's group 1, which is raw or minimally processed foods, basically single ingredient foods. Think about your fruit, your veg, your eggs, unprocessed meat. That's group 1. Then you've got group 2, which is ingredients, so things like honey, salt, sugar, butter, things that you don't eat on their own normally, but you combine them with other foods and use in the kitchen. Then you've got group 3 foods, which are processed foods, which are things like cheese, milk, some cured meats. Normally there's a recognizable mix of a few ingredients, not a long list of ingredients. And there's got to be some processing to make the food edible and to preserve it to an extent that we can have it. And then you've got these ultra-processed foods here in red, group 4. So these are the worrying ones where basically you can't call them food, they're food-like substances, and they're manufactured, they're not cooked, and their sole reason is to make profit for the food industry. They're highly palatable, highly cheap, heavily marketed, don't contain much fiber, so you don't get full from them, and they're problematic really. So the reason they're problematic, well, first of all, I'll show you this. So this is from 20 years ago now, but the UK was the highest purchaser of ultra-processed foods in Europe, at over 50% of our household purchases, which is huge compared to, say, 10% in Portugal or 13% in Italy. And it's no wonder we've got one of the highest incidences of obesity in Europe. But we know that there's increasing associations now of consumption of ultra-processed foods with not only obesity, but cardiovascular disease and also cancer, all-cause mortality, and even maternal outcomes as well, even inflammatory bowel disease. Most chronic long-term conditions now, there's some association with consumption of ultra-processed foods. And I'm sure you've seen a lot of headlines and talk on this topic, and the House of Lords now, I think I've got a committee on it, and there's a lot of more media coverage of this and books, etc. So Food Active have launched this NHS declaration on healthy weight because the government have a mandate to say that the NHS is one of the largest employers in England, has a role to play in keeping its staff healthy as well. And so they highlight that we should be improving the quality of food outlets on hospital sites, and I would extend that to our GP practices as well, in terms of what's on display or what's visible to patients and staff. Implementing regular meal break times. How many of us have a proper lunch break or coffee break at work? Initiatives that promote active travels to work, and then supporting staff who may benefit from lifestyle and weight management services. So this is what we should be doing and the government wants us to do. And there is a digital weight management program for patients and NHS staff. It's free for NHS staff and free for patients. And NHS staff just need to have an NHS email address and have a BMI of 30 and above, or lower if they're from one of the epidemiology backgrounds. And then they can be self-referred onto this 3-month digital weight management program. So it is still running and available for NHS staff and for patients as well. In terms of some of the physiology and health benefits of weight loss now or improved diet, this is a summary schema, just so you know some of the underlying physiology of what's at play. We know about improved insulin sensitivity, which would lead to a reduction in type 2 diabetes and polycystic ovary syndrome. Reduction in systemic inflammation, so visceral fat is pro-inflammatory, and we know that inflammation is at the heart of lots of chronic long-term conditions, including cardiovascular disease. It will lead to a reduction in cholesterol turnover, so a reduction in gallstones. Reduce stigma, improve body image, which will improve mental health outcomes. Reduce sleep apnea. reduced hypertension and CKD because of reduction in blood volume and angiotensinogen, which is part of the RAAS system in the kidneys. Reduction in ectopic fat leading to reduction in non-alcoholic or metabolic associated liver disease, and then reduction in estradiol, so reduction in breast and endometrial cancer. So these are just a summary of some of the possible kind of health benefits from an improvement in weight or improvement in diet. And obviously there's lots of overlap with lots of these, and there's a lot more complex mechanisms at play as well. But clearly there's a lot more bang for your buck if we can focus on weight loss or weight management and improve diet in terms of long-term condition prevention and management, whereas medications obviously would only focus on normally one single pathway and also potentially the side effects as well. So what is the amount of weight loss then that can actually improve certain conditions? So this has been some research that's been done about this, and this is a summary slide on that. So it doesn't have to be that much necessarily, depending on the condition. So for type 2 diabetes prevention, so say you've got pre-diabetes and you want to try and prevent that becoming type 2 diabetes, you only need to lose potentially 2.5% of body weight to have a clinical meaningful improvement in outcomes there. Up to 10%, and then for type 2 diabetes, again, it's similar, and similar for triglyceride reduction. So not that much initially to have benefits. So that's reassuring for us and for our patients that it sounds achievable when you think about 2.5% and working that out. Obviously, the more that's lost, the greater the benefits to an extent, up to say 15% for type 2 diabetes. We know now that it can be put into remission with that amount of weight loss. So other improvements in cholesterol like HDL, and for improvements in fatty liver, talking about 5% at least, up to 15%, which again is fairly modest and achievable. And then for inflammation of the liver, MASH, and major cardiovascular events, outcomes there, you need to at least 10% of weight loss to have effects there, because inflammation has already set in then, and it's going to take longer and more intense changes to improve that. So again, just a snapshot of some of the possibilities there. So I've got another poll for you guys. I'd like you to have a think and pop your answers in the chat for Ellie to have a look at. Which of these medications may promote weight gain as a possible side effect? So we've got atenolol, insulin, gabapentin, mirtazapine, gliclazide, citalopram, amitriptyline, and pioglitazone. 8 possible ones there. Again, you can choose more than one. All except atenolol. Okay, Sally, thank you. Great. Okay. Well done if you said all of them, because unfortunately it is all of them and actually more. So these are the groups on the left. They're known as obesogenic medications because they can contribute to obesity. Antipsychotics are the main group, which we don't normally prescribe ourselves, normally on a special prescription. Those are the main group, unfortunately, that can really lead to weight gain and increased risk of metabolic problems. The diabetes medication, insulin, sulfonylureas, which includes gliclazide and pioglitazone, antidepressant medication, including not only mirtazapine, but citalopram, other SSRIs as well. Beta blockers, so actually, unfortunately, atenolol would be one of them that can contribute to weight gain, and other medications as well, so anti-epileptic medication, amitriptyline, gabapentin, steroids, also the depo contraception as well. So lots of potential medication that we might just simply prescribe without necessarily counseling the patient appropriately on suspected side effects. We might not necessarily look at the BMI before prescribing, so it's just worth bearing that in mind, because 1, is it needed in the first place? 2, is there an alternative that's lower risk? Now, I know there's other side effects as well to be aware of, but certainly it's one to bear in mind. So there are alternatives and lower risk medications for all of these groups that has worked, and some of the popular, some of the more common conditions that we prescribe, for example, antidepressants, certainly fluoxetine a lower risk, which is important to be aware of, and we know that certain diabetes medication is low risk and actually beneficial for weight loss compared to some of the other ones that we prescribe. So now in talking about how we can actually get the message across to patients, we get told about lifestyle advice, just giving lifestyle advice. So what is the lifestyle advice, and who's had any training on how to give lifestyle advice? Giving information hasn't got much impact on behavior change, unfortunately. So it doesn't matter what we say in information, it's not necessarily going to help. Patients and people don't like being told what to do. My 3-year-old doesn't like being told what to do, and I'm sure it's the same for everybody, really. And hearing a healthcare professional's advice is not as valuable or powerful as hearing their own advice, because it feels like someone else is in control, and people like to be in control, really, which is inherent to human beings. So you can inadvertently by giving lifestyle advice, cause a bit of harm, and it can cause frustration. It might lead to a longer consultation. It might be ineffective and not that rewarding if you've not had any training in motivational interviewing or health coaching or brief advice. So language is really important. Like I said, you can cause harm, and these are some of the statements for clinicians on the left that we might say. I think you ought to lose some weight. It might not sound that bad necessarily, but some of them, don't sound that great. You just need to eat less, for example. But some of these can be judgmental. And if you think about the patient's possible perceptions, they can be quite negative, and patients can really feel quite undervalued when we are not that sensitive around weight. We're aware about how to be sensitive around lots of other conditions and symptoms, mental health and, gender and etc. So just another one to be aware of. And again, just to use person-centered language, again, it's a word that's used a lot these days, but it's just using more common sense language, trying to avoid weight stigma. So trying to reflect back what the patient has said, for example. The patient said, my weight's crept up a bit, you can reflect that back to them. Using a third person, so some people find that weight loss can be helpful rather than directly to them per se, for example. Just some kind of other examples of some phrases that can be helpful, but the Obesity UK Language Matters Guide, which is a reference at the bottom, is quite useful, and it's got a lot more information on there about kind of language in obesity, which is important, because these patients end up not coming back to you if you've not said it right, and they might not take any medication you prescribed. If they do get referred to tier 3, they might break down in front of the tier 3 endocrine consultant to say, you're the first person who's actually listened to me properly or spoken to me in the right way. So there are a lot of patients who reported that locally and probably nationally. So we've got some work to do in terms of language. And so again, this is a schema from the same reference document around weight stigma. People can feel like they're being victimized, feel prejudiced, and that contributes to their low self-esteem when they feel that way about the body image. When you've got low self-esteem, it contributes towards depression. It contributes towards low mood and staying indoors, which contributes towards physical inactivity, and all that, and increase in emotional eating or binge eating, and all that will lead to a worsening of the condition, and therefore a vicious cycle of this getting worse. So you can see how we need to be careful really in trying to push that cycle forward and try and make sure that from the beginning it's dealt with sensitively. So I'm now going to show you how to give brief advice in 1 minute. Okay, we've only got a minute at the end of a consultation, so using a 3A's method that's evidence-based, how to do it. So first of all, have they had a recent weight? I've put an arbitrary 3 to 6 months. It could be 6 to 12 months, but have they had a recent weight on the record? If there's no recent weight, simply ask permission. So the first A is ask to weigh them. Is it okay if I check your weight today? And nice and easy. You need to have scales in your room. So if you haven't got scales in your room, then ask your manager to get you those. And ideally, if you've got time, check the waist circumference as well, so you can work out the waist to height ratio. But at least for the referral purposes, if you simply do weight and BMI, then that's the basics. So ask permission to weigh the patient. If they've already got a recent weight or they've done it in the waiting room and brought it in or whatever, then you ask permission again, but to talk about it. Is it all right if I can talk about your weight today? Can I ask how you feel about it? If you weigh them, then you can ask how do you feel about your weight? So a simple, nice, open question would normally get the conversation going, and you can tell straight away whether they want to talk about it, whether it's been hard for them. So it's normally a difficult topic. It's not easy to lose weight, and therefore it's reasonable to show some empathy. Again, it sounds fairly obvious, but we may not have the time or remember to show empathy at this point. But if you do, then you'll go quite a long way. And then the next thing to do is just your simple advice statement. And this is the advice statement that's good. One of the best ways to manage weight is with free support from the local, whatever it might be. I can offer you a referral today if you like, or we can talk about starting the referral process if you like. So that's the simple statement that I'd like you to have a go at saying, rather than going through the details of the diet or what's worked for you in the past. You haven't got the time. This is just brief advice in 1 minute. So simply advising, there's support available that's free, and I can offer you, to start a referral. What do you think? And that might be another telephone call, or it might be a text with some information, or it might be booking a blood test. X could be the health and wellbeing coach at the practice. If you've got one, we've got some now in our PCN, or it might be a social prescribing link worker that might be able to help. It might be the local weight management service in your PCN or region or nationally, or it might be a diabetes service. Obviously, lots of overlap with diabetes and pre-diabetes, so equally there might be able to be a referral there. There's normally something that a patient can fit into if they've got BMI over 30 in most areas, but it does depend on the area. And then it simply depends on assisting them, depending on the response you get. So that's the third A, assist. If you get a positive response saying, oh yeah, that sounds good, doctor, or whatever, and obviously start the referral process, whatever it might be. Obviously, you need to know the criteria, and I'll come on to the National Service Criteria next to finish off with. But once you know the criteria, simply do the form or book the blood test, take the first next step to take the pressure off the patient. If it's a self-referral thing, they're less likely to do it. If you can do the first step for them, then they're more likely to take the next step and go further. You might get a neutral response, which is quite common. You might be like, oh yeah, well, I've been to that service before, or worked a bit, but I've come back, or you might get some form of neutral response, which is fairly common. And again, you can show empathy, accept the wishes, reoffer the fact that, well, if you're still interested, I can still refer you today if you like, or you might suggest a follow-up. Well, if you like, I can, why don't you book a telephone call in 6 weeks or 8 weeks, or how about I send you a text message in 2 months to see how you're getting on with AccuRx, for example, if you've got that in your practice. So that's something to consider for the neutral responses. And obviously, if someone says, no, I'm not in the right frame of mind, I can't be dealing with anything at the minute, I can't focus on my weight, absolutely fine. Accept the patient's wishes. It's not the right time for you, no worries, but the door's always open. If you change your mind, let us know. So hopefully that is something you can give a go. Ask, advise, and assist. Ask permission to weigh, or ask permission to ask an open question. Advise and assist. In the advice, the reason why I've underlined those words is because conversational analysis research in the UK in primary care has shown that if you say the words free, support, local, and offer, you get a lot better response from the patient. So that's why those words are underlined and put in the same sentence. Okay, so now you need to know what the services are. So you probably do already, but just to summarize them for you, and then we'll finish off. So for pre-diabetes or high risk of diabetes, you've got the diabetes prevention program. Okay, it's either face-to-face group or a digital hybrid program. It's a high intensity program, so it's initial one-to-one assessment if it's face-to-face, and then you get fortnightly sessions, 6 sessions, and then monthly for the next 7 months. So quite a lot of sessions, which is good, but I guess patients be aware of that. And it goes over 9 months. It's not just on diet, they're looking to behavior change, sleep, stress management as well, quite a holistic program. And the digital version as well, where you can get apps and health coaches and phone and video calls. So quite an extensive program with lots of options available there. And again, it might be the nurse or the diabetes nurse that tends to refer to these programs, but it might be that this is the one that patient fits into and they don't fit into anything else, and they've not been explained to it properly. And you can send them the link to read more about it, or you can just do this referral form and send it off. So for type 2 diabetes, we've got the diabetes remission program, which used to be called the low calorie diet program. It depends which area you're in, but the NHS are planning to roll this out nationally. We've had it in Yorkshire and Humber. It's a 3 month of total diet replacement, TDR, with low calorie soup, shakes, bars, etc., with support from diabetes dietitians and diabetes nurses, and then 1 month of food reintroduction, again with support from services with education and behavior change support and a health coach as well. But it is all done digitally and a hybrid way. It's not done face to face. But again, fantastic results from that. We've had up to 60% remission rate in our area when I last checked for the Path to Remission program. So really impressive. Can't get that with medication. And then Healthy Living is a relatively new structured education program that's digital for any patient or family member with type 2 diabetes. They can self-refer for this one on healthyliving.nhs.uk. There's pre-existing AccuRx templates that are available, and you can just send them those, and it's just access whenever you like, online education. It's not a formal program that you work through with a health coach. It's just education online, but it's long-term access, and you can self-refer to that. And then for weight management, everyone in the country can access the weight loss app that the NHS has got, which is a 12-month app program looking at kind of low-calorie diet. So tier 1 type of support, very low intensity. And then you've got the digital weight management program I mentioned earlier for NHS staff. It's also available for patients. Patients have to have a diagnosis of diabetes or high blood pressure for this. But it's 3 months of support. It can be with a health coach. It is 3 levels of support depending on what level is needed. And community pharmacy, you can refer patients to this program. It doesn't have to be GPs or doctors that can refer. And then depending on the area, if you are lucky enough to have a tier 3 weight management service in the area we have in Hull, but we haven't in East Riding of Yorkshire, for example, then they can provide MDT support, normally the consultant, dietitian, activity specialist, possibly a psychologist, with group support or individual support. Often quite high intensity with lots of appointments. Often it can last up to 2 years. They might be able to prescribe injectable weight loss medication depending on supply and if they've got the pathway for that, or they might not be. And they might be able to refer you into the Tier 4 bariatric surgery services, again, if the criteria is there and if they've got the surgeons who can do that in your local area. So just to summarize the referral criteria for all of these on one slide for you. Pre-diabetes, as you know, HbA1c 42 to 47 inclusive, but also GDM, gestational diabetes at any stage. So if they've had gestational diabetes at any stage, but the HbA1c is now in the normal range, they can still be referred to the program if they want to. If they want support with anything to do with lifestyle, then they still can, which is quite good. A new diagnosis of type 2, ideally, if you've got the remission program, try and get them into the remission program. However, they have got to be under 65. They've got to be had diabetes for less than 6 years, not on insulin, raised BMI, and HbA1c not too high, under 87. And if they're on medication, you have to go through the protocol and potentially stop or discuss stopping them, but they've got a protocol for that anyway. So that's the best thing for new diagnosis, really, if you've got that in the area. If not, then they've got this healthy living education program. And I'm sure in your region, there'll be some other education program that you can refer to. There will be waiting lists for all these things. That's the other thing. So look at what's not got the longest waiting list and try and obviously refer to those that haven't got the longest waiting list, I guess. And then the healthy living is there. They can self-refer. The BMI was 30, so obesity stage 1, plus or minus diabetes and high blood pressure. The digital weight management program I mentioned, 3 months. Community pharmacy can refer, or NHS staff with a BMI over 30 without any comorbidity. And then obesity stage 2, BMI 35 plus a comorbidity, normally, or BMI over 40, depending on the local criteria. Tier 3 weight management service, which is a specialist service. You probably need blood tests to refer to them first. You might need to screen them for sleep apnea, certainly we do, and fill the form in and then refer them that service. Okay, so these are the national services, and there's probably more in your area as well, but don't forget the national ones. And thank you very much. I think I'm roughly stuck to time there, so hopefully it's been a rapid fire, quick summary of the topic. I'd like to acknowledge these organizations who helped me develop the slides and peer review the slides last year when I developed them. I can give you the full kind of 1 hour plus training if you like for your PCN or a PTL or something, and I can provide free training on physical activity as well and motivational interviewing. But if you prefer e-learning, there's e-learning available via the World Obesity Federation and lots of stuff via British Society of Lifestyle Medicine as well. Okay, happy to take any comments or questions for the next 5-10 minutes or so for those who would like.
That's great. Thanks, Dr. Anand. Is it all right if we take down your slides so that people can see you again?
Yes. It's a shame that you can't see me at the same time. But yeah, my email's on there on the last slide for those who are interested. I can pop in the chat. But yeah, hopefully the slides will come down now.
Obviously, that talk was really fantastic. It's very packed. You can really tell that there's a lot more that you weren't able to cover in there. Thank you. And Sally said in the chat that she found it very useful. As we said, we've got 5 or 10 minutes for questions. Might be that people would like to know more about motivational interviewing. That's becoming so much more important. Another message. Great talk. Thank you from Kaya.
Thanks for the feedback. I appreciate it.
Yeah. In particular, I wondered whether anybody had any questions about the diabetes diet. Was it called Transform? The radical low calorie diet that you offer in
there's the direct study, if you're referring to the direct study that was a few years ago, which showed the benefits of the low calorie diet for diabetes remission. So yeah, there's that, and that's the one that the NHS have looked at to try and roll out. So certainly, yeah, that can be beneficial for some patients who just want to go down the calorie deficit route. And certainly, if you've got the diabetes remission program in the area, then that's a good port of call. Personally, I like the fact that, I like the fact of focusing on real food, personally. So the low-calorie diet will obviously focus on some soups, shakes, and bars that are low-calorie for the first 3 months. So you might get rapid weight loss initially because of that. But then that's not necessarily real food, but then you transition onto real food with support from a dietitian. So there is support available there. But some people prefer plant-based diets, some people prefer low carbohydrate diets. So, and some people might not need to go on a particular diet per se. They just need a bit of advice, a bit of guidance about how they can just slightly tweak their own diet. I mean, the best diet is the one you can stick to, enjoy, and afford. So it doesn't have to be necessarily a huge change, but certainly there is an increasing focus on what's available diet-wise and what can benefit.
Yeah, we've had some great feedback from Julia Visick. Thank you, Julia, who said the Canada Eating Plate was really useful. I've been after a good resource as the UK Eatwell plate is so outdated, as we discussed in the talk. It's not great referring patients for local help when they are then given dubious help. And Sally has agreed with that.
I'm going to put something in the chat here to say that if you like that, the Obesity Canada website in general has got a lot of good resources and e-learning and resources about how to discuss obesity in a 5A method. So if you've got more time, ideally you would do a 5A's approach if you've got more than a minute. And so the Obesity Canada have got guidance on how to do that on a page. I've just talked about raising the issue briefly in 1 minute using a 3A approach, but that website is very good in general for obesity resources and e-learning. And
so is that a brief advice intervention for clinicians 5A approach?
Yeah, you can do it. It is brief advice, but it probably can't do it in a minute. You probably need at least 2 minutes. So mine is very brief advice, which is 1 minute, 3A's. But yeah, if you've got a few minutes, then ideally you can do the 5A method, and that's better. You might want to bring them back. You might want to raise the issue. You haven't got time to discuss it, but maybe you might, depending if you've got the time and resources, you could do a follow-up call, and that's where you might then have the time to do a more of a holistic approach.
That's lovely, thank you. I think we've had some really nice feedback, and it doesn't seem like there are any questions. So rather than keep people longer, and Dr. Anand, we've had so much of your time already, it'd be really nice to say thank you